I'm embarrassed to admit when I hear gynecological cancer, I can barely say it correctly, much less do I give thought to it. And I kind of always thought I had everything covered in that area when I went to my annual exam. I was mistaken and wrong. Today, I'm speaking with Jenna Unke, a physician's assistant at MD Anderson Cancer Center, to learn about the types and risk factors of gynecological cancer. I have to admit, I was kind of surprised at some of them and some signs to look for when something's not right. Stick around. Hey there, I'm Amy Connell. Welcome to Graced Health, the podcast for women who want simple and grace-filled ways to take care of themselves and enjoy a little chocolate in the process. I'm a certified personal trainer and nutrition coach who wants you to know your eating, movement, and body don't have to be perfect. You just need to be able to do what you are called to do. I'm in this season right now. If you've been with me, you've probably realized this, that we are just kind of exploring some broader aspects of our health. As much as I love talking about movement, that's totally my wheelhouse, and food, I totally love to eat food. The reality is our health encompasses so much more than that. This is a conversation I know I really needed. I learned so much and honestly was surprised to hear that when I go to my annual exam, that doesn't always tell my doctor and me the whole story about everything. Jenna walks us through different types of gynecological cancer, signs that something isn't right, risk factors, so much more. This is such an important conversation for women to be a part of. Jenna is a physician's assistant with the world-renowned MD Anderson Cancer Center, where she focuses on gynecological oncology surgery. She's also an ACSM personal trainer and has a strong passion for personal training and nutrition. She and her husband have a 1.5-year-old son, and they love to explore God's beautiful creation and enjoy running, hiking, and camping. For whatever it's worth, this episode focuses on women's health. Obviously, we do use the correct terminology throughout the conversation. So if you aren't at a place where you feel comfortable with other people hearing anatomically correct words, bookmark this, come back at a better time, but please don't skip over it. Before we get to Jenna, I do have a question for you. Do you ever feel shame because you're not following all of the so-called rules of healthy living? You want to break some of these rules with me? I have a new free download I would love to get you. It's combats several health rules that we've heard and gives you a bonus one to keep. You can get it over at gracedhealth.com/bad rules. This will be in the show notes along with everything else. Okay, let's bring on Jenna. Jenna, welcome.
Thank you. Thanks for having me.
I'm so glad you can be here. All right. So I have introduced you before we got on. So everybody knows that you are a physician's assistant. You work in, and I can never say this right, so forgive me, but gynecological cancer, right?
Yes. Gynecologic oncology surgery. Oncology is just a fancy way of saying cancer.
Okay. Gynecologic oncology.
Yes.
And so I'm really grateful that you are here to help educate, if no one else, me, because this is something that I'm not really as aware of. And, as I was thinking about this and I was preparing for our interview, I started thinking, thankfully, there's a great awareness about breast cancer. And especially, we're recording this in October. It's Breast Cancer Awareness Month.
Mm-hmm.
I think last year I got my mammogram. I'm like, go take care of your
Right.
Tata. There's just no shame in this. We're talking about it.
Mm-hmm.
But there still seems to be, I don't know if the word is misunderstanding or if it's just kind of a shame in understanding gynecological cancers. And so I was wondering if you could kind of give me some thoughts on that. Like, why is it, and I'm not going to speak for anyone else, but why is it when I think of breast cancer, I'm like, oh gosh, I really need to be aware of that. I need to be, doing my own assessments. But when I hear about gynecological cancer, I just kind of tend to shift that away. Like, oh, I don't need to worry about that, which is nonsense.
Right. So I think it's kind of twofold. I think that for one, breast cancer is just much more prevalent in women. It is a very common cause of cancer in females. But then secondly, I think that it is uncomfortable for women to talk about their quote unquote private parts, and it makes them feel uncomfortable and they don't like to bring it up in conversation. But, emphasizing a little bit more on the first portion, breasts, there's about 70 or 275 to 300,000 cases of breast cancer per year, which is very common compared to all the gynecologic cancers combined. It's less than that, quite frankly. And so I think just the mere prevalence of it, and something too, they've just done a really good job talking about it. And the breast cancer awareness, they've done a great job, and they've made it more normalized to be able to talk about breast abnormalities, or for women to feel like, hey, there's something going on in my breast. I'm going to talk about it and I'm going to bring it up, and it's okay. And it doesn't feel, as awkward for them. And then, something else though, that's important to keep in mind is that, and I should say, unfortunately, because it would be important if we had a little bit better awareness with the GYN cancers, but GYN cancers overall, in comparison to breast cancers, have a little bit of a lower survival rate. And so that's really important that, if these women did feel more comfortable talking about things earlier, they could potentially be diagnosed with an earlier stage gynecologic cancer, in which then obviously an earlier stage cancer has a higher likelihood of survival. But so yeah, those are kind of the two main things. But when kind of going back to my second point of it's uncomfortable, I have so many women. So every single patient, every single one, I ask them, "Are you currently sexually active?" For me, that doesn't seem like a big deal. And these women, they're 40, they're 50, they've had sex for, almost 30 years, and they still feel uncomfortable. They're like, well, yeah, maybe I do. And I'm like, it's okay. Like, you can talk about these things. It's totally okay. And so I try really hard to normalize things. And I ask those questions first to my patients that I know they probably feel uncomfortable bringing it up. I ask it to them because I want them to give me an answer. Sometimes they might give me a little bit awkward answer, but once they realize, hey, this is a safe environment, you can talk about these things with me. And it's important because if you're having an issue with intercourse, that could potentially mean that there's some abnormality underlying in your GYN organs. So those are the two main things.
Yeah. Yeah. Okay. So you mentioned something that I want to dig into. You said something about, all of the gynecologic cancers.
Mm-hmm.
So this is not like one cancer. This is not like breast cancer or, something in one particular region. I mean, it's a region, but there's different ones. Can you walk me through what encompasses all of the gynecologic cancers?
Yeah. So when we say gynecologic cancer, you're right. It's this umbrella term that we use to describe cancers of the uterus, the cervix, the ovaries, fallopian tubes, vagina, and the vulva. And, doing a little bit, I'm kind of a science nerd. So doing a little bit of like an anatomy lesson
No, I
here.
love it.
So the uterus, we have our uterus. That's where, we have our periods and everything. And when we bleed, that's where it comes from, right? But attached to the uterus at the very bottom portion of the uterus is the cervix. So the cervix is kind of that little opening and that little area right before then you get to the vagina. And then it's our vagina. And then the outside is the vulva, or you might hear the labia or the lips. You might hear these different names. And then off of the uterus on the inside of your body, you have your fallopian tubes, and then you have your ovaries. And so you can have cancers of different areas. So ovarian tissue and ovarian cells look very different under a microscope than what uterine cells look like, or cervical cells. And so you can have just specifically a cervical cancer that would be different than, someone who had an ovarian cancer.
Okay. Got it. So how many is that you mentioned?
5, but there's three really main ones that are the most common, because vaginal and vulvar cancer are super duper rare, honestly. But uterine cancer, cervical cancer, and ovarian cancer are the most common GYN cancers.
Okay. Can we go through some of the symptoms, some of the warning signs for each of those,
Mm-hmm.
and kind of with what to look for or feel
Yeah.
or notice or anything like that?
Yeah. So I'll start with vaginal and vulvar cancer. Like I said, it is super rare to have those, but it's really important that if you have any itching or you notice any new lesions or spots on, the entrance of your vagina or right on the lips of your vulva, it's important to note that, because it can be easy for women to say, well, I just have a yeast infection, let's just use an antifungal, hopefully it'll go away.
Yeah.
But if it persists, it's something important to note to your gynecologist, because there's other stuff that the gynecologist can do to make sure that you don't have any precancer or, hopefully not, but cancer of those regions. So itching of that area is a big one for vaginal and vulvar cancer. But then with uterine cancer, so uterine cancer is actually the most common type of GYN cancer, and you might also hear it called endometrial cancer. So
Okay.
again, more anatomy here.
Yeah.
The endometrium is the inner lining of the uterus. The uterus has multiple layers, but that inner lining of the uterus is actually, premenopausally. So people who have their menstrual cycles, that's actually what your menstrual cycle is. It is the passage, it is the shedding and the passage of your endometrial lining. So your ovaries, which again are, they're kind of attached to the fallopian tubes, which are attached to the uterus, they actually are producing hormones every single month. They're producing estrogen, and that estrogen acts on the endometrial lining and it tells it, hey, it's time to thicken up a little bit. But then premenopausally, you also have progesterone that's also going to tell the uterus, the inner lining of the uterus, to thin out. And so every time, then that's why you have your menstrual cycles. You have this cyclic action of these hormones, the estrogen and the progesterone. Now, postmenopausally, your ovaries aren't supposed to be really producing that estrogen anymore. And so you're not supposed to bleed. You're not supposed to have this thickening of your endometrial lining. But sometimes with things that are precancerous or things that develop into cancer, you can have an abnormal thickening of that area. And then what that means is then you can actually have some bleeding postmenopausally, which is a major red flag. So if you are postmenopausal and you bleed at all, even you go to the bathroom once and one tiny drop of blood or one wipe on the toilet paper and there's blood, you really should talk with your gynecologist immediately, because you potentially could have either precancer cells in the uterus or cancerous cells. But the earlier that you can get in, the better.
Two questions on that.
Yeah.
One, does the risk go up for postmenopausal women? Like, does that change at all because of the hormone difference? Or
Yeah, and as you get older, in most cancers, it is more common in women who are older, different types of cancers. And so, yes, your risk for developing a cancer does increase with age, typically. Mm-hmm.
Okay.
Yeah.
And then going back to if you're bleeding, does that include like it, after sex or something like that? If you're postmenopausal, there's a little bit of blood, still be concerned with that. Cause I think that would be really, I'm not postmenopausal, but I think it would be really easy to be like, oh, well, that's just because of what just went on.
Right. No, and that's true. And so it's definitely something that if you, even premenopausally, it's important to note, like if you're bleeding after intercourse, that's something that you need to pay attention to. And if that's happening, you need to talk to your physician about that.
Okay. So that is the endometrial. Sorry,
Yeah, endometrial.
I'm not science. I'm not geeky.
Uterine.
I am geeky, but I'm not well schooled in this. What's funny? As you were talking, I was thinking I used to have such a greater awareness of the female reproductive system when I was actually reproducing people.
Right.
And now that I'm past that age, I just like, I'm like filed it away and I'm not really worrying about it. So this is like refreshing me from 15 years ago
No,
when I
it's
was like
good.
totally
Well,
engrossed in
and
procreating.
and honestly, even, I feel like from like a premenopausal standpoint, because I kind of was just talking about postmenopausal a little bit more, but a lot of your community is premenopausal, they're in their 30s,
Yeah.
40s. And for them, it's still important to note that if they're all of a sudden noticing that their menstrual cycles are changed, where all of a sudden they're like, wow, my menstrual cycle's gotten a lot heavier, or, that they're starting to bleed in between cycles. Sometimes it can be easy to just think, well, I'm getting close to menopause and kind of just, say that that's all that it is.
Mhm.
But really just being in tune with your body and realizing, hey, this is like a lot different. Maybe I should mention it, because that's the thing, is if you don't even mention it at your gynecologist's office, they may not, they're not going to do a biopsy if you're saying that overall you're doing fine. So it's just important to note, hey, I have been having some heavier menstrual cycles, which again can be a sign of either those precancer cells within the uterus or the cancerous cells. I want to talk about cervical cancer as well, because this is actually technically considered a preventable cancer because we have screening mechanisms for it. We have the pap smear and HPV testing. And so
Okay.
women are supposed to be getting those. Now, it may not necessarily be every single year. I know sometimes people think, well, I'm going to the gynecologist, I'm supposed to go every year, I'm supposed to get a pap smear every year, which the first thing is correct. You are supposed to go to your gynecologist every single year, but your gynecologist will know, if you're someone who needs a pap smear every year versus every 3 years versus every 5 years. So, but you need to go and actually talk about that and get that done. So that's really important, because pap smears are screening just the cervix for cervical cancer. And so if you have abnormalities that come up on the pap smear or the HPV testing, whether it be, again, even if it's just those precancer cells, they're catching those precancer cells before they become cancer cells. And so they, your gynecologist can work with you to follow that closely and to monitor it and to make sure that it doesn't develop into a full-blown cervical cancer. But unfortunately, what we see sometimes is maybe a woman got a pap smear 10, 15 years ago or something like that, but just hasn't been to the gynecologist in a while. And then they come in and they have this and they've been having intercourse and they've been noticing, yeah, I guess I've been bleeding with intercourse, but I didn't think anything of it, and then they finally come in and then they actually end up having a full blown cancer. So I think the most important thing for cervical cancer prevention is to make sure you're going to see your gynecologist every year for an exam, because they're still going to look. They're going to look in, they're going to be able to see the cervix, make sure that everything looks normal, get that pap smear, get that HPV testing. And that really is a good start for those patients. But, the signs and symptoms, again, would be if you're having intercourse and it's super painful or you're bleeding, and again, like you said, even if it's just a little spotting afterwards, you have to note that to your physician, because there could be some underlying abnormality within your cervix itself that's causing that. And then similarly, other symptoms can be vaginal discharge. You may note it, it's normal to have vaginal discharge. So I don't want to say like
Right.
just because you have vaginal discharge, it's a problem. But if you're noticing a change in your vaginal discharge, where all of a sudden you're having a lot more discharge, or it has a different odor to it that you haven't normally seen, or it's a different color, different things like that are really important. And again, the final one would be a change within your menstrual cycle as well, similar to uterine cancer, whether it be you've noticed heavier bleeding or bleeding between your cycles. These are all important things to note for cervical cancer.
Okay. So I heard you say something and I want to clarify it, because when you say the pap smear that's just for cervical cancer.
Exactly. So it is only screening for cervical cancer. So even though, if you remember back to my anatomy lesson, where the cervix
Uh-huh.
is the very bottom portion of the uterus, it doesn't go all the way into the uterus to be able to screen for those endometrial cells or those uterine cells. Because again, they're different. The uterus has different cells than what the cervix has. And so that's important to note too. If a woman comes in and they end up having endometrial cancer, sometimes they say, I got my pap smears every year or every 3 years. Why did this happen? But it is completely different. So it's just screening for the cervix cancer.
Yeah, I would totally be in that boat. Like, I feel like I know this is really unfair, but sometimes I feel like when I walk into a doctor's office, like, they are going to magically be able to know everything about my body, and they're gonna be able to do whatever test or run their blood work or whatever it is, and they're gonna be able to tell,
Hmm.
and I don't have to give anything up.
Hmm. Right.
I mean, not that I would ever intentionally withhold,
Right.
but I think that that is an assumption a lot of people have of like, "Oh, my doctor will be able to tell from the pap smear." Well, sure for the cervical cancer, but what I'm hearing you say, and maybe I knew this at some point, but if I did, I forgot that that's only for that cancer. And
Right.
so I've got something going on in my ovaries. No one's going to be able to know
Right.
because anatomically they're hidden,
Yeah,
right?
exactly. Yeah,
From the annual exam.
yeah, with ovarian cancer, we can't just do a biopsy or do something like that, as a screening mechanism for it. And that's why, unfortunately, with ovarian cancer, it can be very hard to diagnose. And a lot of times, ovarian cancer patients come in at an advanced stage, whether it be 3, 4, stage 3, stage 4. But because they also have symptoms that are extremely vague when they do kind of start having symptoms for ovarian cancer. So things to be aware of with that are changes in your energy level, having extra fatigue compared to normal, having noticing more pelvic pain, noticing that you're feeling bloated, or after you eat you just don't feel quite the same as you used to. You feel like you used to be able to eat a salad and soup and a sandwich, and now it's you take a couple bites and you're just not able to tolerate it. You're like, oh, I feel so full. Changes in your bowel habits, your bladder habits, whether it be all of a sudden now for the past couple of weeks, you've been extremely constipated, but you've still been drinking water. You've still been, kind of trying to eat your fruit and fiber and everything like that. And then with bladder habits, if you're noticing I'm urinating more frequently and this isn't normal. And so that's all really hard because they're so vague and they're so, those symptoms are not like, it's different than the uterine cancer where it's like you're postmenopausal, you started bleeding, that's not normal, go be seen immediately, right? That's why uterine cancers are often diagnosed at a stage 1. But ovarian cancer, so that's why it's important to, even if you're noticing those symptoms, talk to your doctor about it. Don't just say, well, it's nothing, it's probably my GI tract, it's probably just my diet. Maybe it's those things, but if you're really in tune with your body and paying attention to what's been going on the last 2 weeks, 3 weeks, month, and if you're like, man, I really haven't changed my diet, why am I still feeling all this? Or I really, so just making sure that you bring that up to your physician and you talk to them about that. And sometimes, because there's such vague symptoms, sometimes it's really hard. And your physician might say, well, let's just watch it for a bit and see if it gets worse
Yeah.
or if it gets better. Um, and in the beginning, maybe that's okay to a point, but you can't let something like this just go months and months and months where you don't do anything about it. It's important to really talk with them and say, hey, something's not right. I know my body, and this is not my normal. This is not my normal at all. Something is wrong. And really have that open and honest conversation with them, with your physician.
So if you're having intermittent symptoms of
Mhm.
this, like sometimes it's bothering you, maybe sometimes it bothers you during intercourse and then sometimes it's fine. Is that something to be concerned about, or is it like consistently? And then and then also I just want to make sure I'm hearing you right, that if it's happening for like more than a few weeks, that's when it's time to call the doctor.
Yeah, definitely. So to answer your first question, it can be, but it can't be. Again, if it is kind of intermittent, it still could be something underlying. And so it's just important to note it. Even, just tell your
Yeah.
doctor, hey, this has been happening. I understand it hasn't been happening for a couple weeks straight, but I notice it X amount of times. They can help make that determination how they want to monitor that. Do they want to get imaging? Do they want to follow closely? But definitely what you said, secondly, was that yes, if it's happening for 2 weeks, 3 weeks, 4 weeks, and it's staying and it's constant, let your doctor know.
Okay. All right. Yeah, all of these symptoms are easily dismissible.
Yeah.
I mean, it's just, you hear these things and you're like, whatever. Yeah, I ate something funny, or I haven't had enough water, or, I mean, it just seems like it would be really easy to miss all of this.
Yeah, it definitely is. And, in our day and age today, we're all so busy. And so it's easy to let weeks go by where you don't even realize, like, oh, I guess it has been happening for a while. But that's why I think it's just so important to really just pay attention to the little things, because those
Yeah.
little things that last and then maybe get a little bit worse and a little bit worse. It's important to really realize that and notice that within your own body, because it makes a difference.
Yeah. Okay. And then, okay, so we talked about cervical, we talked about ovarian, we talked about uterine.
Yeah,
Did we talk about
we
uterine?
talked about
Yes.
them all. We talked about them all.
Golly.
There's so many.
Okay.
One, two,
So I
three,
had
go.
so many. Okay, well, I did have a couple questions as we went along, that things that just popped in. So, when I'm thinking about the uterus, when I'm thinking about, like all of the gynecological, golly, I sound like an idiot. Gynecological region. Two things that come to mind are, number one, and I don't think that they're related. They're not related, but one is endometriosis, which I don't really know a whole lot about,
Mhm,
but I know that it's in the uterus,
mhm,
right?
yes.
And so, is there any kind of correlation between uterine cancer and having endometriosis, or extra things that you need to be worried about?
Right.
So I'll start with that, and then I'll go to my second question.
Okay. So really good question. So endometriosis is a little bit different. So basically with endometriosis, what it is it's an implant of endometrial tissue. So again, that was the lining that's within the uterus, that when the ovaries are working premenopausally, they're acting on it with their estrogen and telling that to thicken and grow. So think about that. If you have an implant and you have this endometrial tissue that's implanting outside of the uterus, so what it does is it'll go maybe on the ovary, or it'll implant kind of along the outside of the uterus, or along other areas within the abdomen, or even on the colon, on your bowel.
Oh, wow.
And then what
Okay.
ends up happening is that then every month when you have your cycle, you end up growing these little implants, because that estrogen then is acting on that endometrial tissue implant, and it's saying grow thicker, and so it can grow and grow, and so these can become larger implants or masses, and then they end up, they can cause a lot of pain. And again, if it's on the colon, it can cause you issues when you're trying to have a bowel movement. It can be painful when you're having intercourse. So some of these symptoms are kind of the same as what I was describing, especially for ovarian cancer. But bottom line, you should tell your doctor about that, because even if you have endometriosis, if it ends up being endometriosis, then there's still treatment for endometriosis that they can try to help you with. Now, good thing is you don't have cancer, and it doesn't necessarily increase your risk of cancer or anything like that, but it's still, so even if you have those symptoms that are super similar to some of these GYN cancers, bring it up to your doctor, because then they can provide the workup that they would need to do.
Okay. Okay. And then the other thing I was wondering if there's any kind of correlation about is if you have an IUD,
Mm-hmm.
does that increase the chances of it? Or, because a foreign object sometimes can, throw our bodies out of whack.
Right, right. So really good question. So IUDs they're intrauterine devices. That's what it stands for. And
Mhm.
basically what it is this little device that gets inserted within, so it kind of goes through the cervix and within the endometrial canal, and that's where it hangs out. And now there's different types of IUDs. There's one specific one that doesn't necessarily, it's a copper IUD. It doesn't have any extra medicine. So that one works a little bit differently, where it doesn't have any hormones or anything. So it's more so just creating like an unkind environment within your uterus to prevent pregnancy. Whereas the IUDs that have progesterone in them, which again, remember that was the another hormone that's typically produced. So progesterone IUDs actually work really well to normalize out the tissue within the endometrium. So before, if you remember me talking that the estrogen, that's what makes it thicker. The progesterone that makes the endometrial lining thicker. The progesterone is what thins it out. And so actually using a Mirena IUD, or, there's other types, but the progesterone or hormone type IUD can normalize out that tissue. So it actually is considered like a protective factor for, not a risk factor, but a protective factor for endometrial cancer. And we use Mirena IUDs for treating either precancerous endometrial cells or even a very low grade, low stage endometrial cancer. So let's say someone
Wow.
gets endometrial cancer and it's like a stage 1A, grade 1, really low, but they're young and they're like, I don't, or, they just don't want surgery in that moment right then and there. And so we can potentially do an IUD that has that progesterone. And what it does is then it normalizes out that endometrial tissue and it treats that area locally right there in the uterus. And then now they still are going to have biopsies. We're not just like, oh, you're good. You've got your IUD. You're good for 5 years, right? We have to actually check it and make sure that there's been no growth of abnormal tissue or anything like that. But yeah, it is actually beneficial.
Wow.
Mm-hmm.
That's really cool.
Mm-hmm.
Okay. So you've told me about all these symptoms and signs to look for. Is there any kind of a genetic component to any of these cancers or all of them?
Yeah, there actually is. So one of the big ones is BRCA mutation or BRCA mutation, which a lot of people have heard of this before because it's related to breast cancer, and a lot of people know a lot
Yeah.
of stuff about breast cancer. And so BRCA, there's a couple different ones. There's BRCA1, BRCA2, but regardless, they both increase risk of breast cancer, but they also do increase risk of ovarian cancer. And so it's super important to know not only, do you have a BRCA mutation, but really looking at what's your family history. If you have two aunts that have breast cancer and your grandma had ovarian cancer, that's important to tell your physician because they may say, oh, you have these cancers that tend to be related to a BRCA mutation. Has anyone in your family been tested for BRCA? And so that's really important to note for those because it is quite significant how much it can increase your risk. And so knowing that ahead of time, there's preventive type measures that you can do if you do have one of those mutations. And so the goal is always, because what ends up happening sometimes is maybe a woman gets diagnosed with breast cancer. And
Hmm.
then, because with a BRCA mutation, that can happen in younger women. And then they find out they have this mutation. And then we end up seeing them in our GYN clinic because it makes a difference. They're at an increased risk of
Oh
having
gosh.
ovarian cancer. And
What
so
a double whammy.
yes.
Gosh.
And we do not want that to happen, right? It's
Right.
already enough to go through one cancer, right? We don't want you to have to go through another one too. So there's preventive things that we can do for those women. A lot of times we end up we follow them closely and we do screening and different things like that up until they're at an age where we feel it's appropriate to remove the ovaries. But it's really important to note that because if they know it ahead of time before if they know, hey, here's my family history. I'm 25 years old. Should someone in my family get BRCA testing? Do I need to get BRCA testing? Because if they 10 years from that point we're going to get a breast cancer, they could possibly prevent that by finding that out in advance. So that's a big one for ovarian cancer. And then for endometrial cancer, there's also something called Lynch syndrome. And Lynch syndrome, people who have Lynch syndrome have an increased risk of developing endometrial cancer. And it's also associated with colorectal cancer. So again, same type of situation where if you have a family history and dad had colon cancer and grandma had endometrial cancer, you might tell that to your doctor because they might say maybe someone needs to be tested for Lynch to make sure that you don't have that, that you don't potentially have that either.
Okay. That's really good to know because I don't know that I would have ever thought, oh, if I have a male in my family
Right.
who has had that,
Mm-hmm.
that should be anything that should be on my radar in terms of my uterus.
Right.
Yeah.
Right.
Yeah, I mean I never would have thought about that. So if you have like what more than one person who has had either colorectal or any kind of a endometrial, then that's something to tell the doctor.
Honestly, anybody with cancer is important. Like
Anybody. Okay.
anything, because their a family history, even if one person has something, no, they may not be able to check a Lynch syndrome on you. Maybe you don't qualify for that, but it's still important because then, let's say you start developing symptoms. Like, let's say you have this remote history of someone once in your family had ovarian cancer. Maybe it was a great great grandma, but nobody else. But then all of a sudden you start developing those vague symptoms. Your physician, just knowing that there's that one person that had ovarian cancer, might think, okay, we really should make sure that this woman doesn't have ovarian cancer, right? So any cancer, it's important to note that to your physician.
And what I'm hearing you say is it doesn't necessarily need to be on my maternal side. Like it
Right.
could be my dad's grandmother
Yeah.
or, something like that.
Yeah.
Like it can be,
Mhm.
it can be either
Yeah.
side. Okay.
100%.
Okay.
And
Mhm.
another
Uh,
thing too with, I know I said the male colon cancer thing, but if a male in your family, males can have breast cancer. So if a male in your family
yeah.
has a breast cancer, that's super important to note as well. So, any cancer, tell your doctor, tell your doctor about it.
Got it. That makes sense. That makes sense. Okay, so you are in addition to being a physician's assistant extraordinaire,
Mhm.
you are also a personal trainer. So that tells me that you have even a greater awareness of just how the body works together and all of that kind of stuff. So I'm wondering if you see a difference in how patients react to treatment, in the ones who maybe walk in with a solid foundation and they're regularly moving and being active and feeding their body well, versus ones who may not do that as much.
Mhm.
Does that make a difference?
Yes, I do feel 100% it can make a difference. We do still have random patients that'll come in, they're super healthy, their weight is appropriate, they've been eating healthy, they follow an active lifestyle, and yet they still develop cancer. I don't know
Yeah.
why. I don't know why that happens. But that being said, those women do tend to do better through their cancer treatment. A lot of times, a lot of the first steps in certain GYN cancers is doing surgery, removing certain gynecologic organs. And so someone who has previously been, they work out a couple times per week, they eat really healthy, they go into their surgery and they're able to actually recover a lot quicker because they have a little bit more muscle mass that they've built up, just over
Mhm.
however long that they've had this active lifestyle, compared to someone who's completely sedentary. Maybe they're obese, maybe then because of that they have hypertension, they have other health problems, they don't do as well in recovering. They're going to have a harder time recovering. And something that we really promote too within our GYN department at MD Anderson is that we enhanced recovery after surgery is what we call it. And what it is it's kind of a lot of like healthy stuff, actually, like, really making sure that after a surgery, they're up and moving around immediately, right? Like, I'm not
Wow.
telling these people stay bedridden for 4 to 6 weeks because that's the whole time, like that's the time that your doctor allowed you to stay home from work, right? No, we're like, get up right away, like on the same day of their surgery, get up, move. The body does better in healing
Yeah.
itself when you're active. It really does. So that's definitely a big one. But even, people that are going through chemo or going through radiation, chemo can really cause a lot of different symptoms. So can radiation. But with chemo specifically, you can get shortness of breath, you can get extreme fatigue, things like that. Whereas if a person is coming in and they've been someone who they like to go for a walk every single day, or they go for a mile run or whatever it may be, they have a higher cardiopulmonary capacity. Their lung capacity is better
Mhm.
than someone who's sedentary. So even if they're experiencing that shortness of breath and that fatigue, they're going to be able to kind of work through it a little bit easier than someone who's already short of breath at rest because they're just not used to it. And then with radiation, people who do yoga or do different range of motion exercises, even during their radiation, that can really help because radiation can it can cause changes in your skin where your skin feels stretched and burned. It can change range of motion. It can decrease that range of motion. So just being able to stay mobile, flexible, strong throughout your treatments is really, really important. And I always encourage that with my patients as well, that if they're able to tolerate it, keep on exercising and keep on eating healthy. Don't feel like, oh, I'm going through treatment, I can't do anything. If you can tolerate it, 100% do it.
Yeah.
100%, keep that normal lifestyle for yourself.
It seems like the last maybe 10 years, there has been a real shift in like, oh, stay in bed, recover, prop
Mhm.
yourself up, all of that to no, get out and
Right.
move your body. And, I remember even just after I had C-sections, and after I had my second one in particular, I was like, okay, I'm getting up and I'm moving. And they
Mhm.
were like, oh, I don't know. Are you should,
No.
and they were fine. They weren't discouraging it,
Yeah.
but, yeah, there's a whole shift. I think in all healing. I mean, my son, when he had meniscus surgery, they were like, okay, get up and get moving. And, Sherry Fletcher, who was on a long time ago, but, she had ACL surgery. They're like, get up, get moving.
Mhm.
So, yeah, that seems to be a trend, which totally makes sense, right? Like, because your blood delivers the nutrients to
Exactly.
your body, and you need the nutrients to heal.
Exactly. You know the science. Look at you. You
I know that science. I obviously don't know, or at
yeah,
least don't remember.
exercise is just so important. And I don't even mean exercise, just being physically active and moving
Moving.
your body
Yeah.
is super important. And from a cancer standpoint, these men and women, are going through really difficult times mentally. You get told you have cancer. That is a major mental, mountain
Yeah.
to have to climb over, right? And then not only were you just told you have it, but now you're supposed to get through it. And you're supposed to go through all this treatment that they have all these side effects. And so, that's why it's important. We know that exercise produces endorphins. We know that people going outside and just tuning into nature and other things, it is beneficial for people mentally, emotionally, and then obviously physically if they're getting up and they're moving and they're able to do that. And so people will feel happier after they go for a little walk or something like that. So it really can benefit people, who have cancer, just all around, physically, mentally, emotionally.
I want to shift gears just a little bit. I know you are a Jesus follower, and I know that you don't work in a faith based organization. So I'm just curious how your faith plays into your relationship with your patients. Um, you know, I know that we don't just check Jesus, out when we walk in the door of a work, or wherever we're going, like he's always with us. And so how does your faith play a role in what you do on a day-to-day basis?
Really good question. So, one thing that's really great, first off, I'm going to say kind of as MD Anderson as an institute, not even just me personally, but MD Anderson as an institute, we're a cancer center. That's what we work with. All of our patients, they have cancer. And so they understand everything that they're going through and that they need different types of spiritual assistance with things. And so we actually do have a really good spiritual department or spirituality department at MD Anderson. And we have chaplains and we have different things like that that are able to help patients. So, if a patient says something, or if I offer it up to a patient and say, do you want to see a chaplain or do you want to speak with someone on this? We have that
Mhm.
available to them just in like a broader sense. So
That's
I know
great.
that a lot of
That's great.
patients really appreciate that. But then for me personally, I think that God gave me this role as a physician assistant working with cancer patients to truly be a servant to those patients and be a giver to those patients and serving them in the absolute best way that I can with the highest quality of care, being kind to them, showing them compassion, trying to empathize with them and understand that even if I have a patient who comes in and is a little bit cranky with me and kind of has a sour attitude, you know what? They're about to go through their sixth cycle of chemotherapy. They don't feel good. They do not feel
Yeah.
good. They don't, and so just really being understanding towards them and being there with them. And if they're having a hard time, say, hey, let's talk about it. What are you thinking? What are you feeling right now? And I think that, Jesus loves us so much and God loves us so much in so many different ways. And so just being able to share that and show that Jesus love to these patients, just the characteristics of being caring, being loving, being honest with them, patients appreciate that. And so I think that for me, it's just how I act and how I speak with my patients. I don't have to tell them, hey, I believe in Jesus and this is what I think. I just showing them those characteristics that are like Jesus. I think that's the best. That's the best thing, that the best role that God has really given me to do in this position.
Yeah, I love that. I love that. And I think we can reach people and make them feel loved in so many ways without ever saying the name of Jesus. Hopefully that just lives through us.
Mm-hmm.
I love it. Okay, are you willing to answer a couple questions that I have started asking my guests? One of them is an easier one. Well, I shouldn't say easier, but anyway, I'll just ask the questions. So, the first one is, do you have a meaningful Bible verse that you would be willing to share? I asked a friend of this one time. I said, what's your favorite verse? And she was like, that's like asking me to say what my favorite movie is.
Yeah.
Like, do I want a drama? Do I want a comedy? So I've switched to meaningful.
Okay, that's good, because I do have one specific section of scripture that I really love, but I won't do that. I'll just do one verse, and the one verse that I really love is actually my husband's confirmation verse, and it is Joshua 1:9. Have I not commanded you? Be strong and courageous. Do not be afraid. Do not be discouraged, for the Lord your God will be with you wherever you go. I love that.
I love that. Yes. Yes. I love that. Love that.
And I think something like that too is, for patients who are religious and things like that, I really do think that that helps them get through, right? They realize that God's there with them, and they, even in this difficult time, he's there. He's helping them be strong. He's helping them be courageous. He's helping them not to be afraid. He's with them wherever they're going to go. So I think that that's probably why I really like that one. It just pertains to anybody and everybody.
Yes, it does. It does. I'm sure God put that on you because he knows where you are serving people and where you can help get that or help them with that. That didn't make any sense. I think you know what I'm talking about. Hopefully, my listeners can hear it too. Okay. So the second question is a little different. I am fascinated by tattoos and by body art. I do not have any, but for some reason, this is a conversation that comes up about once a quarter. Like, well, if you had to get a tattoo, where would you put it? So I'm curious if you have any tattoos, because what I have found is when I notice one and I ask someone about it, oftentimes there's a really cool story that goes behind it. And I have connected in so many different ways with people, random strangers off of the story behind their tattoos. So I was wondering if you had one, if you were willing to share it. And if not, what would you get and where?
Okay, so I do have one. My husband and I both got one a couple years ago for our anniversary, actually. And so it's on the inner portion of my arm, and it's the words "do more," and it's written in my handwriting. My husband has his same words, "do more," written in his handwriting, which, by the way, his handwriting is so much nicer. But mine is mine, and I still love it. And so what it kind of initially started as, it's like this family motto for us. We wanted to do more for each other, do more with each other, out in God's creation and everything, do more for God. And that's kind of how it started, where it was just kind of those three phrases. But over the last couple of years, it kind of has also become this reminder to always strive to reach that potential that God sees in us. He doesn't intend us, his special creations, to just sit around, watch our life pass by. He wants us to go out. He wants us to experience his absolutely gorgeous creation. He wants us to find better ways to serve him and to be willing to take risks, knowing and having the faith that he's there with us and he's going to help us through it. And even though sometimes the things may seem risky or scary to us as humans, but just remembering, again, God is right there beside us. He's saying, don't worry, I got you. And then the bottom line with it is, my husband and I were like, We do not want to look back on life and think, man, like, I wish we would have done that. I wish we would have, and have
Yeah.
that type of a regret, because who's to say that God isn't looking down and thinking the same exact thing, thinking, yeah, I wish you would have done that. I wish you would have walked through that door that I opened for you rather than walk right past it. Right. There's so many opportunities that God puts in front of us that feel scary. But if we really have the faith that God's walking with us through this. I think that's the most important thing. So just do more,
Then we can do more.
for God, do more.
I love it. Oh, that's fantastic. That's really great. Okay, Jenna, if people have questions, now I don't know if my listeners are like me, but sometimes I have a tendency to absorb something and something might like stick and I'm like, okay, I want to think, and I'm just going to think about this for a while. I'm not a very good like action, like go out and do. If people have questions and they want to reach out to you privately, or just want to learn more, how can people get a hold of you?
So they can either follow me on Instagram. My handle is at Jenna Unke. I know it's a weird name. I'm going to spell it JennaUnke. It's a very German last name. Or you can send me an email at jennaunke@gmail.com. And I would be happy for anyone who wants to reach out if they, any resources regarding cancer awareness, prevention methods, screening protocols, healthy eating, healthy exercise, different things like that. Just even dealing with anxieties of cancer diagnosis. And, even if you don't have cancer, but you probably know someone with cancer and you just want to learn a little bit more, reach out to me. I'm happy to talk with you. I love education. It's like my favorite part of my job when I get to do patient education. So please reach out. I'm here to support you.
Awesome. All right. And we will put that in the show notes as well. Hey, thank you so much for your time today. This was educational for me. If nothing else, I have learned and I know of symptoms to be aware of and things to pay attention to. And I think my biggest takeaway for this, at the end of these episodes, I always try and do the one simple thing. So I'm going to have to think about that. But I think the one simple thing is don't be afraid to talk to your doctor. Just say something and do it sooner rather than later if you're having an issue.
Mm-hmm.
Do you think that's a good one simple thing? I'll let you decide what my one simple thing is. Here we go. Here we go. You tell me, what's my one simple thing to remember today?
I think the one simple thing, do not be afraid to talk about what's going on with your body, even if it's in your quote unquote private region. Talk about it with your doctor, pay attention to what's happening and the changes in your body and talk about it with them. They're your doctor. That's what they're there for.
Yeah, that's good. All right, there we go. So Jenna completed my one simple thing for today. All right. Thank you so much.
Thank you. Thanks for having me.
Okay. I don't know about you, but I'm definitely going to start paying more attention to everything. Like I mentioned, I have a tendency to think that if I'm going to the doctor, that'll just check the box and she'll be able to tell me everything is okay. If it is, assuming it is, but that's not the case. I'm sure you can tell how just warm and welcoming Jenna is and how nothing will face her. So please reach out if you have any questions at all. I know she would be more than happy to connect with you and just be a sounding board or answer any questions. Don't forget to get your download, How to Enjoy Shame-Free Health by Breaking 8 Rules, at gracedhealth.com/bad rules. If there's anyone you know whom today's conversation would serve, I would love it if you would share this with them or post it on social media. If you haven't subscribed to the show, I invite you to do that. Click that button, subscribe, so you can get your own Graced Health each week. All of these things really help the show. What's the one simple thing I want you to remember? I do this every week. You heard it straight from Jenna. I actually don't even need to say it here. If something doesn't seem right, say something. Even if it seems like a little issue, it's worth making a call and talking to your doctor. Okay, that is all for today. Go out there and have a graced day.